Doctor, this is a very difficult name. Karjini from Aga University Hospital. You are welcome.
Okay, hello and good afternoon, everyone. So today I'd like to present to you our initial experience at AKUH University Hospitals on ureteroscopies and laser lithotripsy. Just to give you a bit of an introduction, stone disease is actually more common in Kenya than we previously thought. An initial study done in the 1990s by Ndirangu and colleagues looking at a period of 10 years at Kenyatta National Hospital, they only saw 82 patients who presented with urolithiasis. This was followed on by a more recent study by Professor Ngugi in 2010, and in his series of 5 years, he managed 178 patients. We also know that the modalities for treatment in Kenya are improving with regards to management for stone disease, and the data, unfortunately, on current practices locally and regionally are limited. So today I'd like to present you an audit of all the patients we've managed with ureteroscopies and laser lithotripsies between the period of January 2011 and December 2013. Before we go on to looking at my data, I just wanted to give you a little bit of a history or introduction to when our equipment was made available to us at AKUH University Hospital. And the first laser machine was actually introduced in 2006. This machine was privately owned by one of the urologists and had to be brought in every time he needed to use it. The hospital then subsequently purchased the laser machine in 2008, which was then available to all practicing urologists at the hospital. Rigid ureteroscopes became available in 2005, and flexible ureteroscopes became available from about 2006. But as you know, these instruments are quite fragile and from time to time get damaged. So there have been periods of times in the hospitals where the flexible ureteroscopes were not available and private surgeons had to either buy their own or do without them. So between the period of 2011 to 2013, we saw 227 patients. And as you can see, there's a steady increase over the years with almost double the number of patients between 2011 to 2013. Most of our patients were males, and more than 50%, almost 70 to 80% were men, and this is consistent with a lot of studies done around the world. In terms of stone size, we saw a range of stone sizes from between 2 to 40 millimeters, with the mean stone size of about 9.7 millimeters. Majority of our patients lay between the group of 6.1 to 10 millimeters, followed by 10 to 14 millimeters. In terms of the stone location, about 74% of our stones were located in the ureter, followed by 22% within the kidneys, and some of them within the bladder itself. And as you can see, within the ureter, majority of the patients had stones within the proximal ureter. In terms of stone location, again, equal numbers between right and left-sided. However, we did see about 10.8% of patients who had multiple stones and about 1% of patients with bilateral stones. In terms of patients managed as a primary procedure, majority of our patients were successfully managed just with one procedure alone, giving us a rate of about 93%. However, we did have some patients who required initial stenting prior to a definitive procedure, and this was about 7% of our patients. In the patients who required two procedures, the majority of stones were located within the kidneys at about 53% of our patients, and about a third had stones within the proximal ureter. Only one patient each had stones in the mid-endostal ureter. Most of our patients had stenting done routinely after ureteroscopy and laser lithotripsy, but as you notice in the recent years, routine stenting is not being done. And about 39% of our patients in 2013 did not have routine stenting. In terms of rigid and flexible ureteroscopies, we also see an increase in the number of patients who underwent flexible ureteroscopies over the years. Only about 13% of the patients had stones that were sent for analysis, and these were patients who had bilateral stones, multiple stones, or recurrent stone disease. And of these patients, you can see that the majority of the stones were calcium oxalate, with a few having calcium oxalate and phosphate, and very few having mixed stones. With regards to inpatient admission or duration of admission, we see a significant increase in the number of patients that have been managed as day cases, with more than half of our patients last year going home on the same day. With regards to those that were admitted, we also see a decrease in the number of patients staying in hospital post-procedure, giving us a mean hospital stay of 1.8 days. And with regards to complications, we saw 4 complications over the period of 3 years, giving us a rate of 1%. Of the complications, we saw 2 patients who had urethral strictures requiring surgical treatment, 1 patient with a urethral injury requiring stenting on the 2nd postoperative day, and a 3rd patient who had incomplete fragmentation of a lower pole calculi coming back with impaction at the VUJ requiring a 2nd procedure. So then how do we compare with the rest of the world? Unfortunately, like I said, the data on stone management within the country and regionally are limited. So I went internationally, and when we looked at mean hospital stays, in the literature or a study done by Triantafyllides in Greece, he found that it was 2.8 days, and this is in comparison with 1.8 days that we got at Aga Khan. In terms of a need for secondary procedure, this was quoted at 6% compared to our 7% at Aga Khan. And in terms of complications, we saw a range of between 1.8 to 8.8% in the literature compared to our 1% over the last 3 years. Unfortunately, I'm unable to give you a success rate in terms of stone clearance, as we don't routinely do postoperative imaging in our patients, so this is a downfall, but perhaps a prospective study would be in order to determine this. So in conclusion, we see an increasing number of patients being managed with ureteroscopies and laser lithotripsies in Kenya. And this could probably be alluded to either patient awareness, knowing that their stones can be managed locally, but also to physician awareness, knowing that our other colleagues are able to refer the patients to us. There's also improving skills within the urologists in the country in endourological techniques, and also increased availability in the hospitals of equipment within the hospitals itself. We're also seeing that we're having shorter hospital stays with negligible complications in our series of patients. And unfortunately, I'm unable to give you a stone clearance rate, but I can imagine it will be probably pretty good, given that we have very few patients who represent. And finally, we hope that our volume of work will likely increase in the future with improving modalities of treatment, including PCNL techniques that we'd like to introduce, and laparoscopic techniques, and also increasing skills within the urologists in the country. Thank you.
Lithotripsy is increasing, and as you have seen, more than 50% increment in the last 1 year. And we thought, what would be the way forward in future, in case we wanted some guidelines locally, in case we wanted documentation of stone clearances, as Dr. Naji had said already, that maybe we see them when they come to the clinics back, but we need to, in case of auditing, like now, we couldn't find them in the files. So we just wanted kind of how best can we capture these things. And the other thing is, we also wanted to know the sites and the sizes, and you can see the mean was very high. Actually, it was more than 9.7. So, and because we are refining our skills in the PCNLs and learning more with mini punctures and micro punctures, so we thought that maybe these patients are the patients who could benefit from these other minimally invasive surgeries. And I think maybe in the next year we may present something more prospective and more of a mixed data. I think we'll open to question. Thank you.
You still have time, at least 2 minutes only. Kani, then Taka, then Gai.
Thank you. I'm looking at the use of ureteroscopy, and despite what Kahi and Dr. Naji have said, were you able to clear all the stones, even in the, you have not told us about bigger stones in the kidney, you have no complication rates, you are okay, but this is another issue of when you have a huge stone burden, and from my experience that will not be that easy, because how are you going to clear all the stones in the kidney using a ureteroscope? Even nothing, you did PCNL, there's no way you abandoned a procedure because your patient bled, you did have septicemia. I think since the two heads are there, and I know there are bosses.
Let Taka ask his question, then Mungai, then they can answer.
Who are these patients? When you presented these numbers, who are these patients? Do they belong to the hospital or Dr. Naji? I've operated there. Were my patients in that? So we need to know who these patients are. And I don't see any of our administrators of AKUH Hospital here. It would have been fruitful if they were here to hear out Dr. Mahesh Desai of what they are doing in Nadia and how far back AKUH Hospital has been in investing in equipment, because ureteroscopies and laser lithotripsy have actually begun in Nairobi since 1999.
Great.
And long.
Keep then the time's going. Great.
Let me use your microphone. Yes. It's a good presentation, and for a start, in terms of what we're doing, is a good thing. It shows us the increasing, maybe not an increase in stone burden, but an increase in awareness and in treatment. But there are many things you could do. In terms of stone clearance, where it is possible to have the need to wait when you come to the clinic, if you're using an image intensifier, all you need to document is whether you have cleared the stone during that time of your ureteroscopy or not. You do not need to have a post-operative X-ray to tell you that you have cleared the stone. Now, this AKUH Hospital is a learning institution. It's probably the only learning institution in which you have this armamentarium available. Are we allowing any of our SHOs to do this? Is there any hope for them to do that? Thank you very much.
I think I didn't want to leave out, since we are one of authorities in stone. I think we give Mahesh Desai a question to ask before we.
Very nice presentation. I think if you had added the total stone clearance rate, it would have been perfect. Now, why it is necessary? One thing is, stone is a recurrent disease. If you have completely cleared the stone, still there is a 17% chance that you will form a new stone. But if you left the residual stone, there's 70% chance that you will form another stone within 2 or 3 years. So it is very, very important from the medical legal point of view also. Now, when do we do that stone? Because you fragment the stone, and then probably within a month those fragments will pass out. So when you put a DJ, in most of the cases, when they come back for removal of DJ, that time you should do a X-ray. We now do a CT, plain CT, because plain X-ray sometimes misses a small stone, and then they will, next time they have a colicky, they have a CT scan, and then the stone will be shown. So we would like to know exactly, and then if you left a DJ and if you have a residual stone, it's easy to go and do it. Are you using a urethral sheath for the flexible ureteroscope? You're using it? Yes. That's right. Because sometimes, it doesn't go, and most of the time if you are doing a large stone like what you did yesterday, people may have to do once or twice. I mean, average 1.8 times they use the stone if the stone is more than 2 centimeters. So there is a limitation of ureteroscopy best for the ureter, but if you are using for the kidney, there is a chance that you may have to double check again, or you may have a second procedure to clear the stone completely.
I think
But good paper.
IDD is going to give a few answers on behalf of the young lady, because they did the study together.
Actually, I just wanted to respond to Dr. Kanye, who raised very relevant questions. But I will just summarize and say that is the side or problems of an audit. We can only audit what we can see in the files. And all those things you raised may be there, and I think we will capture them in the prospective studies. The other thing of Dr. Thacker, I think, to whose patient, I think, to me, it might be irrelevant for me to, if we are going to study, maybe we will take all the patients as the same, and the outcomes to be the same, so that everybody should be the same as well for the outcome. And I think he's right, so thank you very much.
I think